So now we have Professor Dr. Ramamurthy, and he'll be talking on mastering pre-op measurements and interpretation, predictable ICL outcomes. All to you, sir.
Thank you so much, Sonu, and I have no financial disclosure relevant to this presentation. I think these are the principal things that we look at in preoperative measurement, that is refraction, objective and subjective, acceptance at 12 millimeters vertex distance, the anterior chamber depth, which is to be from the corneal endothelium, the white-to-white measurement, and the K reading and topography. It's because it is this white-to-white measurement, K reading, anterior chamber depth, which has a significant impact as far as the sizing of the lens is concerned. Needless to say, the other aspects of the anterior segment and the posterior segment, especially in the highly myopic eyes, have to be checked very well. And a very accurate refraction where the subjective acceptance of the patient is most important rather than the objective refraction. And ideally, these patients have to be off contact lenses for a week before surgery if it's soft lenses, 3 weeks if it's a semi-soft or hard lens. Obviously, we're not doing anything to the cornea, but still I would like to follow this dictum because the quality of the refraction as well as the accuracy of refraction could be influenced, especially if it's a long-time contact lens wearer with some amount of warpage. Accurate estimation of the cylinders and torics is extremely important. And one other thing I do is that in case there is a 0.5 to 0.75 diopters of with the rule astigmatism, which many of these young patients have, I make a superior incision because I usually do a 3 millimeter incision. Just in case for cost reason the patient is not interested. Almost 70-75% of the ICLs I use a toric. But just in case the patient has just about 0.5 diopters of with the rule astigmatism, I do a superior incision. I think there will be a video also on that. And this is the most important factor in the sense that endothelium to the anterior capsule, it has to be at least 2.8 millimeters. But this was a dogma that was created in the minds of people. Initially, Starr used to say it should be nothing less than 3 millimeters, though we went ahead and used 2.8 millimeter. But today we are trying to stretch the limits. I think Kimiya Shimizu has come up with the concept that he has done eyes up to 2.5 millimeter. Maybe it's not for the beginners, but we ourselves have started doing, after looking at the lens size and various other factors, up to 2.6 millimeters, we are doing a control study to detect whether we can stretch the limits in these extremes of eyes. Maybe we can discuss about it a little later. And we need an internal ACD. One of the things you need to remember is that whether it's Pentacam or many of your instruments have as a default setting from the epithelium to the anterior capsule. So you have to make sure that either you detect the epithelial, the stromal thickness, or you dial it in such a way that it measures from the endothelial aspect. And this is something that needs to be done in every case. And one very important thing that needs to be remembered is that higher the power, whether it is minus powered lenses or plus powered lenses, these are the ones which are thicker in the periphery. Because this is where you are sort of, the patient begs you, you're also somewhat tempted to bend the rules in the sense that if it's a minus 18 diopters, obviously you don't want to do a clear lens exchange on that patient, not fit for laser vision correction, and he or she is very keen on a phakic intraocular lens, but has a 2.6 millimeter. But then these are the eyes where you have to strictly adhere to the criteria. But having a center of flow or a PI is not going to help you as far as bending the rules is concerned, because there is a crowding of the anterior chamber and crowding of the angles which you are bothered about. So once you have, please remember, it's not just sizing alone that matters. The AC depth and the keratometry is also important. When you supply the data to the company, they use all this data to determine the sizing the lens. So getting the AC depth as well as the keratometry is as important as getting an accurate white to white. And again, as a thumb rule, the size of the lens is about 1 millimeter more than white to white if the ACD is in the range of 3 to 3.5 millimeter, which is very often the case. If it is less than 3 millimeters, it's one step less, that's about 0.5 millimeters less. And if it is more than 3.5 millimeters, the sizing of the lens is slightly more. So obviously it stands to reason. Obviously, if you have a smaller eye with a shallow AC, you would put a smaller lens, and vice versa if it's a larger eye with a deep AC. So as far as this was the point I was trying to make, just in case you have a very high myope or even a very high eye probe, where it's a plano-concave lens, is the periphery which gets thickened out, and these are the cases where you tend to stick to the dictum of about 2.8 millimeters, and it's the eyes in the range of about -6, -7 diopters, where in case you want to do phakic intraocular lens because of cornea being inappropriate, maybe you could consider 2.6, 2.7 millimeters, but large studies have to bear it out that this is the right way to go. I think the standard of care as far as measuring white to white is concerned is still the digital calipers. This has to be done in the OR with the patient anesthetized with a speculum in place under the operating microscope. That's when you get the most accurate readings. You can do with the OpScan, Pentacam, Topolizer, etc. But let me just come to this slide. Basically, these are the various measurements that are possible with different machines. Obviously, it will stand to reason that because the lens goes into the sulcus, a sulcus measurement would be most appropriate. It is possible with the UBM, but most phakic intraocular lens manufacturer as well as the ICL, as of now, is based upon most the white-to-white measurements rather than the UBM measurements. With most UBMs, the problem is that the sulcus itself is an ill-defined area. And if you have the same person measuring in one eye of the same patient at two different times, sometimes you get two different variable readings. So it's important that we stick, as far as now, we stick to the white to white, though artificial intelligence based formula, etc. is coming into vogue as far as sizing of these lenses are concerned. And as I already mentioned, digital calipers is the gold standard. And what you find over here is that Pentacam and Topolizer seems to line up pretty closely to them. But if it is anything based upon laser interferometry principles, they are not measuring white to white, but they are measuring sclera to sclera. And that's the reason that the measurements that you get with them is slightly higher. And that's you have to account for that in case you are using like a IOL master, and it's not the right instrument to be used for white to white measurement in these cases. And as I already mentioned, phakic IOL size is about 1 to 1.25 millimeters more than white to white. In case you are going by the sulcus to sulcus measurement, it's about 0.35 millimeters. This is as far as eyes of standard configuration is concerned. You get surprises of the sizing only because not all eyes are the same, and it's several other factors like the lens rise also plays an important role in this. And using the calipers, I think all of us can afford this. The calipers has to be well calibrated, and I already mentioned it has to be done under the microscope. And please understand that the white to white, the limbus is not a single line, but it's obviously a zone. And essentially what you have to measure is from the mid limbus to the mid limbus. Leave the blue alone, leave the white alone, but carefully under the microscope, go to the central area and measure from the mid limbus to the mid limbus to get the most accurate measurements. And this is also something I mentioned that all of our eyes follow the principles of enantiomorphism in the sense that the white to white of the two eyes should correspond to each other. Just in case the white to white of one eye is very different from the other eye, it has to be suspect. And we always do it with the OpScan, with the vernier calipers, digital calipers, as well as with the Topolizer. The reason being that in case and most often we go with the Topolizer measurement because the instrumental measurements is always better to rely on. But if there is a pigment or a blood vessel right at the limbus at the 3 o'clock or 9 o'clock meridian, the instrument might include that. And that's the reason that you want to measure with the calipers also and make sure that all these in both the eyes together line up. And especially in a keratoconus eye, because you might have a central steepening over here, and if you essentially go by this AC depth and size your lens, then there could be excessive crowding. That's the reason when we use a toric ICLs in these situations, we always bring down the measurement by 0.5 millimeters. It's also been said that you can take peripheral AC depth measurements also and incorporate them. But algorithms to measure ICL sizing based upon peripheral AC depth is not available. So it's a good idea, especially if there's a significant central steepening. And nowadays, usage of toric ICLs in case of keratoconus is on label. It's not off label any longer, especially it's a well-centered keratoconus. And these patients do benefit, so you do well to bear this. And finally, it's a good idea to have a look at the scotopic pupillary size. And now with the EVO available, which is of a larger optical diameter, these patients seem to do well. But just in case it's a young myope with a very large scotopic pupillary size, at least you must forewarn that patient that he or she is going to may suffer from halogen glare subsequent to the implantation of these lenses when the pupils enlarge beyond the size of the optics of the lens that you are implanting. I think the success of the phakic intraocular lens surgery depends almost entirely upon accurate and precise measurement of the preoperative parameters. I'm sure the previous speakers would have made excellent presentations. The surgery itself is quite doable for any reasonable anterior segment surgeon, even though you operate within the confines of 3 millimeters between the anterior capsule and the endothelium, and not 8 millimeters as in the case of phacoemulsification. But then it's doable. But then to get optimal results, it's not just the refraction alone, but the entire analysis of the anterior segment that's extremely important. Thank you so much for your kind attention.
Thank you, sir. So to summarize, you actually mean to say that the ICL surgery is now available for the entire gamut of range of myopia, starting from low myopia to any level of high myopia for keratoconus also. And then any of the people can practice ICL surgeries, and no fancy gadgets are actually required, and no fancy tools are actually required for ICL or phakic IL implantation.
I think our numbers are also constantly dropping. You know, when I started refractive LASIK 1997, I said -30, no problem, I'll do LASIK on you. Simply because we didn't understand there was nothing like keratoconus that was known to us. Slowly dropped down to -12. Now, anything beyond -7 or 8 diopters, anything beyond 3 diopters of hyperopia or astigmatism is phakic intraocular lens, which we go for. And again, if the patient, I always believe that laser vision correction has a lifetime, in the sense that even though you have achieved emmetropia initially, over a period of 5 to 10 years, there's some amount of regression. But phakic intraocular lenses, what you get till the onset of presbyopia, cataract, that's what the patient is left behind with. So the patient with a -6 diopters, extremely insistent, looking for absolutely crystal clear vision at the end of surgery, and doesn't want any compromise in the quality of vision, I would always tell him or her that this option might be better suited for you. And there are quite a few takers for that.
True, very true. Any quick question for Dr. Ramamurthy? We can have one or two questions as we are ending the session. Dr. Bharti, any quick comment or quick advice to the house for the phakic lenses?
I think there are two take-home messages. One is that a fancy gadget like excimer laser machine or a femtosecond laser machine is no more a necessity for a refractive surgeon. Anyone who can do a good refractive.
But you have to buy the lens.
So buy the lens, and you are making money out of buying the lens. You are not making immediate money by spending 5 crores, my dear. So that is one thing, because there is a kind of restriction on how much you can spend and make. And the second thing is that variety of a whole range of spectrum of all kind of refractive errors which you can kind of do with the excimer laser or a femtosecond laser. Majority of them you can correct with the phakic IOL also. So I think that the take-home message is that if there is any reservation in your mind as to whether you can do a intraocular surgery or not, I think that reservation should be over. And there's a big competition between the two procedures now, I think.
Thank you, sir. Vardhaman, do you like to add a quick point?
Yeah, right. So I think, of course, we have spoken about all the points. And again, reiterating the same thing is actually your sizing is the most important thing. And you have to always make sure that probably you have 2 or 3, if possible, gadgets to collaborate your findings. And usually the sizing is very predictable. It is uncommon to have possibility of exchanges. Number 2, of course, is that just make sure that whenever you are actually analyzing the patient, ensure that the patient is analyzed in terms of cornea well whenever you are taking a call, because I see so many patients who have been actually told to do laser when they are actually having significant skewing, significant asymmetry, and can lead to ectasia. So these are the patients that a lot of people miss, and they should have undergone phakic lenses, but because the surgeons are not probably doing phakic lenses, they do LASIK on them. That should not be done. And it's a very simple procedure to perform. Anyone who does a good phacosurgery, I think it is a cakewalk for sure. And definitely the numbers are dropping in terms of diopters, as sir has said. So right from -2 to -18, I think you have a complete range in which you can do it. And it has also become one of the primary options now. There are patients who come to me now, and even if they have -4, they do ask for ICL many times. Yeah.
And there are
Yeah, please.
In cases of this post-cataract, sometimes if you're doing a lot of ICLs, then you're getting the cataracts also. Some modification in the biometric calculations, or even
No.
if you do the Indian ICLs, then
So
There
actually,
are no modifications needed because the ICL thickness in the center is just about 50 microns. And whether you're doing an immersion A scan or whether you're using a
Optical
biometer, it does not alter the axial length readings in any way. And since the cornea is untouched, you can just go ahead with the use your usual formula. And I think so. No, it won't make any difference. It doesn't.
No modification.
and it's very easy to explant. I mean, through the same 3 millimeter incision, the ICL can be explanted and the cataract surgery can be proceeded as required. So in my practice, I would offer the patients all the 4 ranges, PRK, LASIK, SMILE and phakic lenses, and then let them choose their own, and the advantages and disadvantages is given to the patient. And I think almost 30% of the practice has now become for phakic lenses. And with the addition of EVA Viva, I think more is yet to come when it touches the presbyopic collections. I think.
even when we run the toric ICLs, if we get some surprise in the toricity, can we rotate and all that? Can we do
So you just need to go and check the vault. If these patients have a low vault, you need to, you can go one step ahead, one size ahead. If it is, you go re-rotate. If it still rotates, you need to go one size up. So actually, vault is the major predictor for toric rotation.
The other factor you need to keep in mind is what is the spherical equivalent of the residual refractive error? Because if you rotate the lens, you are not introducing any power, you are just redistributing the power. So if you have -1 diopter spherical with +2 diopters of cylinder, rotation of the lens will help. But if we just have -1.5 diopter cylinder left over or +2 diopters of sphere left over, rotation is not going to make any difference. In that case, the wrong power has been put in, a lens exchange may be necessary. Rotation, so we have to make sure that the spherical equivalent is 0. And in that case, if you send the data across to STAR, they themselves will tell you how exactly to position this lens.
So one thing is that the lenses are customized nowadays. So they're like, you put it a 180 because they are all customized lenses, no?
Some companies do that, but then, because of the very large inventory that's required and the speed of delivery, these people, they deliver the lenses, but the amount of rotation that's needed is less than 22 degrees. And that's quite acceptable. It works quite well.
So I think thank you very much, and thanks for attending this STAR Symposia, and thanks to the chair, co-chair, and the speakers. Thank you very much.